The use of intravenous vitamin C during cancer treatment is a controversial topic. It is never used as part of the standard of care in America or any Western country, but it is a staple of integrative treatment, having been administered in integrative cancer clinics literally millions of times. So what is the reality? In this video, we will examine the mechanism of action of intravenous vitamin C and human trials attesting to its efficacy. As always, these ideas are discussed in more depth in the book Cancer Self-Defense 101 – Quick Tips to Help You Survive. All citations for studies quoted in this video can be found in the book's bibliography at cancerselfdefense101.com. This video is intended as information, not medical advice. It is not intended to treat, diagnose, or cure any disease. Any medical advice should come from an appropriately credentialed medical professional familiar with your unique circumstances. The history of vitamin C use against cancer. The first inkling that vitamin C could have beneficial effects against cancer came from an observation in 1959 that cancer patients exhibited many scurvy-like symptoms. Vitamin C is the cure for scurvy. In fact, vitamin C's scientific name, ascorbic acid, is a reference to its ability to cure scurvy. A meaning away from, scorbic meaning relating to scurvy. Inspired by this idea, Scottish surgeon Ewan Cameron began treating 50 terminal cancer patients with high doses of vitamin C in 1974. Some of the patients received intravenous vitamin C, 10 grams per day for 10 consecutive days. Some patients received higher doses. Some received oral vitamin C, 10 grams per day, and some received oral and IV-C. The results were mixed but encouraging. Some of these patients, who were given no hope for survival, experienced tumor regression. A 1975 follow-up case report described a patient who had experienced resolution of his lung tumors after being treated with high-dose IV-C. Signs of disease returned when his daily dose was reduced. When his dosage was increased, he again achieved remission. These encouraging results led Cameron to collaborate with legendary two-time Nobel Prize-winning chemist Linus Pauling, who also shared the belief that IV-C could be beneficial in cancer treatment. They administered IV-C to an additional 50 terminal cancer patients and reported on the 100 total that had received IV-C. They showed that the IV-C group lived over 300 days longer than historically matched controls. These impressive results prompted a group from the Mayo Clinic to try to replicate Cameron's and Pauling's results. Their study, however, had a fatal flaw. They administered 10 grams of vitamin C only orally instead of including an intravenous component. Naturally, they achieved no benefit. Because their experiment had a control group and because of the stature of the Mayo Clinic, Cameron's and Pauling's results were discredited. The National Institutes of Health even put forward massively flawed research based on studying urine levels instead of blood levels, stating that vitamin C levels in humans could not reach the levels necessary to kill cancer. They even insultingly wrote that Pauling did not understand the difference between orally and intravenously administered vitamin C, even though Pauling explicitly wrote about the difference in his published studies. Oral vitamin C has many mechanisms controlling its levels in the blood: intestinal absorption, tissue accumulation, renal reabsorption and excretion, and potentially even the rate of utilization. When vitamin C is administered intravenously, these mechanisms are bypassed, and pharmacological levels of vitamin C can easily be reached. The 10-gram oral dose of vitamin C used in the Mayo Clinic studies would have produced peak blood concentration of less than 200 micromoles. The same dose given intravenously, as in Cameron's and Pauling's studies, would produce peak concentrations of nearly 6 millimoles, more than 25 times higher. In Phase 1 trials, 100 grams of vitamin C administered intravenously has been shown to safely achieve blood levels of 25 to 30 millimoles. Cell line studies have shown that concentrations between 3 and 7 millimoles are necessary to kill cancer cells. Mechanism of action. IVC's primary mechanism of action against cancer is by increasing reactive oxygen species, ROS. Cancer cells cannot handle this increase and commit apoptosis, a tidy form of cellular suicide. Interestingly, vitamin C has a dual function in the body. It acts as an antioxidant at blood levels between 30 to 80 micromoles, levels achieved by oral supplementation, and as a pro-oxidant at levels between 0.5 to 20 millimoles, the levels achieved by intravenous administration. Cancer cells are notoriously unable to handle increases in reactive oxygen species. Human trials. Now for a summary of the human trials. Cameron and Pauling attempted to bolster the case of IVC again in 1978 when they performed a follow-up to their 1974 and 1976 studies, stating that 22% of the IVC-treated group of terminal patients survived 1 year, while only 0.4% of the controls did. In 1982, a group out of Japan confirmed Cameron's and Pauling's results, with the IVC group surviving over 5 times longer than the control. Yet in 1985, the Mayo researchers doubled down, producing yet another flawed study, and IVC's reputation was immeasurably damaged. It would be a full decade until IVC was to re-emerge in the academic literature in the form of isolated case studies. Then, in 2005, the results of a phase 1 trial found that IVC was pharmacologically safe in late-stage cancer patients and even extended patient survival. Since that time, there has been a growing interest in IVC. There were 57 clinical trials examining IVC's effects against cancer between 2002 and 2021. One 2018 meta-analysis of 23 of these trials found that IVC is efficacious and has been shown to be safe in nearly all patient populations, alone and in combination with chemotherapies. A quick summary of some of the clinical trials. People with stage 3 or 4 ovarian cancer were randomized to receive standard of care chemotherapy or standard of care chemotherapy concurrent with 75 grams or 100 grams of IVC twice weekly for 12 months. The IVC group had an 8.75-month progression-free survival advantage with fewer side effects. Another study examined IVC, 1 grams per kilogram, in 97 refractory non-small cell lung cancer patients concurrent with hypothermia treatment and best supportive care versus hypothermia and best supportive care alone. The IVC group had an overall survival of 9.4 months versus 5.6 months in the control group. The IVC group had a 42.9% 3-month disease control rate versus 16.7% in the control group. A retrospective study in patients with bone metastases compared the effects of radiation concurrent with chemotherapy versus radiation concurrent with chemotherapy and IVC. IVC reduced pain while extending survival from 2 months to 10. Several other clinical trials in other cancer types are enumerated in Cancer Self-Defense 101, Quick Tips to Help You Survive. Why IVC is not standard of care. Despite the encouraging human trials, the chances of IVC becoming part of the standard of care are slim to none for the foreseeable future. Harvard medical professor Dr. Lewis Cantley and Baylor College of Medicine professor Dr. Ji-hee Yoon opined why IVC languishes in such a disreputable state despite encouraging clinical and preclinical evidence. There are at least 3 challenges that have thus far prevented large-scale, randomized, controlled trials of intravenous vitamin C for cancer therapy. First, vitamin C is not patentable. Therefore, there is no financial incentive for pharmaceutical companies to support vitamin C clinical trials, and those that have been done have largely relied on government grants and small private donations. Second, as discussed above, vitamin C cancer therapy has a long history of controversy. Due to the Mayo clinical studies in the 1980s, many orthodox mainstream clinicians have a prejudice against vitamin C therapy. Third, although many preclinical studies showed high-dose vitamin C could kill cancer cells or retard tumor growth in vivo, vitamin C's mechanisms of action have not been clear, making it hard to predict the pharmacodynamics, the rational design of combinational therapy, and biomarkers for patient stratification. More information about intravenous vitamin C can be found in the book Cancer Self-Defense 101, Quick Tips to Help You Survive.